Please welcome Dr. Deb St. Fard. She is going to be our master of ceremony tonight. Dr. St. Fard is an associate professor of physical medicine and founder of the CU Women's Sports Medicine. Dr. St. Fard is a former elite athlete. She competed in the shot put at the 1987 World Champions in Rome and the 1988 Olympic Games in Seoul, Korea. She is an accomplished athlete, a respected physician, and a regal woman, mother, friend, and phenomenal motivational speaker. Please welcome Deb St. Fard.
Welcome. I feel like this is my 50th birthday all over again, but better and bigger. I just have to say that when I was a kid growing up with an older brother in Columbia, Maryland, my family, I was born in Haiti, Port-au-Prince, Haiti, and we moved here when we were little. So my dad taught my brother how to play soccer in the backyard, and I sort of learned by watching those two play, and that was the extent of my involvement for a little while. And then growing up, playing soccer, and then getting involved in sports. So I was born in '64, and Title IX came around 1970, and just opened up huge opportunities for girls in sports, girls and women in sports. And that has changed my life. And having all of you all here to hear what our academicians have been thinking about and what we teach about, and the care that we bring to active and athletic women and girls and their husbands and sons and fathers, and then getting to share that with you guys is really a dream come true. I also want to make sure I point out to you guys this card that's in your materials. In case you want to contact any of us, there's information on the back to do that as well. I grew up, and we moved from Maryland, and we went to Kansas, and I'm a sprinter. I don't know if you can tell by looking at me, but I am a sprinter trapped in a shot putter's body. So I went out in junior high to be a sprinter, and I said, I want to sprint, coach. And he said, okay, let me watch you run with the other girls. And so I ran, and he said, okay, why don't you try the shot put? And I'm like, well, what is that, and where is that? And he's like, I don't know, it's over there somewhere. But anyway, I was good at it. And so I kept sort of getting better at that, while all the other sports, I never made it to nationals and those types of sports. But Kiara, I had that, were those pictures floating around? Old school? Let's see. Okay, old school pictures. So I ended up doing the shot put and the discus at Princeton, and then started weight training, and I'm probably 20 pounds less muscle now than then. But what I noticed going along was that the boys always seemed to have, quite literally, better facilities, literally better coaches, and better doctors. And I thought, why is that? And so as I continued to go, one of the things that I cared very much about was creating some equalization between what girls were afforded to support their sports dreams, to at least be equal, if not better, than the boys. And so tonight is a celebration of just that. All these women here are athletes, super smart people, and we're just, and so I'm excited that with Judy Regensteiner Center for Women's Health Research and the WISH, the clinical arm of women's care in WISH, with Mitra Razaji leading that, and Kiara, making all of this happen for you guys to educate you regularly about lots of things that you're interested in. It's really neat. The fact that a hospital has the vision to support active and athletic women and girls being healthy at it, and providing them the facilities, the resources, and the expertise. A lot of times girls, I have 11 and 13-year-old girls, and it just occurred that maybe my 13-year-old doesn't want to be talking about her, I shouldn't say this out loud, her newly started period, with a male doctor. And so it's so nice to have, options for women and girls to be able to speak about things important to them in terms of pursuing their hopes and dreams, but with also people with whom they could just feel very naturally very comfortable. So that's what we're going to do tonight, is do all that. We're not actually going to, well, you're going to talk, Dr. Court's going to talk probably about some hormones and menstrual periods, and Dr. Walcott too around the knee. So you'll be surprised how it still relates, but at least we can make sure all of our research is including women and then being dispersed to women and girls too. So I still have 5 minutes. What am I going to do for 5 minutes? You want it? Sure. I'm going to give it to you. Okay, I will yield the floor. So let's see if there's anything to talk about. So that middle one, I was the flag bearer for Haiti. They said, you're the strongest one here. You might as well carry the flag. I'm like, yes. Okay. And those are my girls hiking up on the Continental Divide July the 4th, Skylar and Shayna. And so I thought that my life was all about the Olympics. I thought my life was all about being a doctor until I had my first child and realized, this is what it's all about. So I'm glad I had that opportunity to be their mom. Okay, so with that, we were going to move on. Did I miss any other housekeeping things you guys want to shout out at me? Did I get the housekeeping? Anything else? Okay. So our first expert is Dr. Wendy Court. Dr. Wendy Court is who, if I had dreamt right, who I would have dreamt to be. She has added so much to our understanding of women's health, the ability for women to participate in sport, for women who have fallen off the ability to participate in sport, can they catch up? She's been able to answer all of these questions. She is fully NIH funded, respected internationally and worldwide. And she almost made me join her practice 12 years ago when I came here, and I had a total career crisis because I thought I have to work with her in research. But I stayed a clinician, so. But she kept on the good work. So you're going to hear about her great work tonight. And she, is there anything else I need to say? She's a leader in the field of aging. She's a professor at the University of Colorado School of Medicine. She directs the research for geriatric medicine. She's also the co-associate director within the Center for Women's Health Research with Dr. Judy Regensteiner. Within the Center for Women's Health Research, she's an internationally known expert on factors that influence your bones during exercise and the effects of estrogen during menopause. She is also very happy to have completed building her new home up in the mountains, and we are all invited right after this meeting. Court.
Thank you, Deb. Can you hear me? Great. If this feels like Deb's celebrating her 50th birthday all over again, I'm celebrating my 60-something birthday all over again, which means I'm more than a decade older than her, which kind of surprised me that she brought up Title IX, because I know exactly when Title IX was enacted, 1972, because it was the year I started college, and it meant that I had a college volleyball and basketball career. So, I wish maybe I would have been 10 or 20 years later because the opportunities would have been even better, but boy, am I grateful that I came along when I did. So I'm going to talk to you today about exercise and bone health, conventional wisdom and contemporary ideas. And I'm going to break my talk down into 3 general areas. First, I'm going to give you a little primer on osteoporosis. Then we're going to talk about the conventional wisdom side of this. And when we get to contemporary ideas, I want to talk about the role of nonsteroidal anti-inflammatory drugs in terms of how they affect our bones and how our bones adapt to exercise. And then I'm going to talk about calcium metabolism, because we know that's really important for bone. So let's start out with a little bit of background on osteoporosis. There are many bone diseases, but the primary one that's influenced by exercise is osteoporosis. It's also the most prevalent bone disease. So that's why we're focusing on this one. And we define or diagnose osteoporosis either by measurement of bone mineral density. That's done on an instrument we refer to as a DEXA scanner. You just lie there, this low-dose X-ray goes through your bones and tells us what your T-score is. And if you have a T-score of -2.5 or lower than that, that's an index of osteoporosis. That's Judy's talk. Or even if your bone density is normal, but you've had what the doctors refer to as a fragility fracture, let's say you fell, but maybe you shouldn't have had a fracture with that fall, then that's another way that we can diagnose osteoporosis. And if you've got a T-score that's a little better than minus 2.5, but it's not better than minus 1, then you're in the range of low bone mineral density, sort of a pre-osteoporosis state. Any bone in your body can suffer an osteoporotic fracture, but there are some very common sites. The wrist is one. When you fall and catch yourself, various regions of the spine are susceptible to osteoporotic fractures, and the hip is a common site. And the hip is the one that is really the most concerning to the healthcare system because of the morbidity and mortality associated with those fractures. 1 in 5 individuals who has a hip fracture will not live more than 1 year. And a much higher percentage than that never get back into their homes to live independently. They end up in long-term care facilities. The prevalence of fracture, any osteoporotic fracture now, is extremely high, higher than the prevalence of diabetes or of heart disease. Half of women over the age of 50 will have a fracture, and even 1 out of 4 men will have a fracture. We used to think that osteoporosis was only a woman's disease, but that's not true anymore. We know that men also develop osteoporosis, but they develop it about 20 years later than women do. And it's a very sneaky disease. There are really no overt indicators that you're losing bone and increasing your risk for osteoporosis, except loss of body height. So one crude way, it's not an accepted way of diagnosing osteoporosis, but one crude index is whether you have lost more than 2 inches in height. That is probably an indicator that the bones in your spine have suffered small wedge or crush fractures and they're compressing, and as a result of that, you're getting shorter. Now, the good thing about this disease is that there are many drugs available to treat it, and these drugs have been found to be very effective, not only in increasing your bone density, but in preventing fractures. Now, let me walk you through this slide, because it's kind of complex. This is the kind of slide we put in a research paper, and I usually don't change my talks from a research audience to a lay audience. I want to inform you how to interpret research while we're going through this talk. So these are drug trials where a large group of women in this case were randomized either to get an active drug or the placebo drug. And then they're followed over some period of time, and they look at the number of fractures that occur in both of those groups. And if the number of fractures was the same, in other words, if the drug was not effective, then these dots over here that we call point estimates would all line up on 1. The relative risk of getting a fracture on the drug would be the same as the relative risk if you were not taking that drug. But the fact that all of these point estimates are to the left of 1 means that the incidence of fracture was less in the drug-treated group than in the placebo group. And in fact, if these all line up right around 0.5, we can say that your relative risk of fracture was reduced by 50% as a result of being on that drug. Now, the other thing that's on this slide are these horizontal lines. And that's a kind of a statistical measure of confidence. How confident are we that that drug really prevented fractures? And if those lines do not cross 1, then we are at least 95% confident that if we did that same study again, we'd get the same result, and that drug would be found to be just as effective the next time. So this slide shows you that there are several drugs that have proven anti-fracture efficacy. And I'm not going to go over what each of these drugs are, but I want to point out that the first 6 of them all work by slowing the rate at which bone is lost. The rate of bone loss is referred to as resorption. So these are anti-resorptive drugs. The other drug up here at the bottom is the only drug we have that is pro-formation. It's actually like an anabolic stimulant to your bone. It causes your bones to increase their mass and their size rather than just slow the loss. And it's the newest drug we have out there, so even though it doesn't show effectiveness on this slide, there's more research being done to demonstrate effectiveness. And I want you to remember that drug for later in my talk. That's teriparatide. Now, I wanted to make one other point. In terms of therapies to prevent hip fracture, you do not see exercise on this slide. And that's because there have been no studies, no randomized controlled trials to determine whether exercise is truly effective at preventing fractures. But we have observational studies of exercise. And here's a similar sort of slide that I just showed you. Now, in studies where people have been asked how active they are. Are you a couch potato, or are you a weekend warrior, or are you a dedicated exercise enthusiast? So they're asked questions about how active they are, and then they're divided into the most active group being compared to the least active group. So when we do these types of comparisons, for the most part, people who are more active when compared to less active are less likely to incur hip fractures. And again, the relative reduction in risk on average is about 40 to 50%. Now you might notice there's a bunch of studies represented up here that were conducted in women only, and most of those show benefit. A few included women and men, and in general, the ones that included only men don't seem to be as convincing because a lot of these horizontal lines cross one. But I don't think that means that exercise is less beneficial for men. In general, the studies of women involved much larger groups, and that translates statistically into reducing the size of those horizontal lines. So I think if we would conduct larger studies in men, we would probably see very similar results, that exercise seems to be effective in reducing our risk for hip fractures. So let me summarize what I've told you so far. I've got really strong evidence that I shared with you from randomized controlled trials that there are multiple drugs that effectively reduce risk for fracture. In contrast to that, we have only moderate evidence, because they've been only observational studies, that physical activity might reduce fracture risk. I haven't told you this yet, but you have to believe me at this point, that if we look at how much either drugs or exercise can increase bone density, drugs win every time. The magnitude of increase is much larger than the increase we can get through exercise. So given this, why should we bother prescribing exercise? Because it's a whole heck of a lot easier to give somebody a pill than it is to tell them to go out and exercise every day. Well, I think there's at least 3 reasons in my mind why we have to keep exercise front and center. And the first reason is that exercise is a lifelong therapy. We've got really good evidence. So this is looking at bone mass over the lifespan. We've got really good evidence that if we get kids to do the right kinds of bone-loading exercises, like jumping off this stage, that increases the peak bone mass that they develop. We've got fairly good evidence that during young adulthood and midlife, times when we should be able to preserve our bone mass, that people who are active do that better than sedentary people. And then we've got some so-so evidence that when the aging process starts hitting in and we have an inevitable loss of bone, that the rate of loss might be slowed in people who are active compared to those who are sedentary. Now, if we contrast this with drug therapy, that usually isn't initiated until relatively later in life when substantial bone loss has already occurred. So even though these drugs can be effective, it might be a case of too little, too late. The second reason that I think exercise needs to remain front and center is more theoretical. So this is hypothesis according to Court. And these are animal data that I'm going to share with you now. So what I'm showing you on the left side of this slide are things that we can measure in humans, bone mineral content and bone mineral density in response to 2 drugs that are used to treat osteoporosis. So you can see these drugs in these animals. These are probably rats. These drugs caused a nice increase in both BMC and BMD, about 15% on average. What I'm going to show you on the right side of this slide is a measure of bone strength. And it is a direct measure of bone strength, which is why we can't do these studies in humans. So investigators actually find out how much force has to be applied to the bone to cause it to fracture. So we know that these drugs improve bone strength, but they improve it by an amount that's relative, that's proportional to the magnitude of increase in bone mass. So an increase in bone mass of about 15% translates into an increase in bone strength of about 15% on average. Now here's a similar slide, similar study done in animals where the intervention is no longer drug, but exercise. It's mechanical loading of the bone, and it's compared to the non-loaded contralateral limb. So I told you earlier that exercise or loading doesn't increase BMD as effectively as drugs. Here's some of the evidence for that. Relatively small changes in bone mass and bone density, but these translate into huge increases in bone strength. Not a proportional increase, but a 10-fold greater increase in bone strength compared to drug. And so when I think about this, I think that if we give somebody a drug, they take it orally or it's injected, it's going to bathe the entire skeleton. That drug doesn't know where the weakest region of the skeleton is and where new bone needs to be formed. But when you exercise, and if you exercise appropriately, you can target regions of the skeleton that need to be made stronger. So exercise can influence skeletal metabolism in a more functionally and structurally appropriate manner than drug. Hypothesis according to Court. The final reason, the third reason why I think exercise needs to remain front and center is because it can reduce fall risk. So I've already suggested that exercise can help make your bones stronger, so that's likely to reduce your risk for fracture. But exercise, unlike drugs, can also favorably influence things like balance, mobility, and strength, and make you less susceptible to fall that way. And if you're not falling as much, you are less likely to fracture. So that's your primer on osteoporosis to start out with. Let's go on now to the conventional wisdom. What types of activities, what types of exercise are most likely to have beneficial skeletal effects? We measure the effect of loading in bone by measuring something called strain or microstrain. And we know that we have a physiological or a normal level of strain that our skeletons are exposed to during day-to-day activities. So that's represented here by what I've called the physiologic window. And you really, if you want to build new bone mass, everybody familiar with the term overload principle? You know, if you want to increase your muscle strength, you've got to really stress your muscles. You can't just lift 5 pounds if you want to be able to eventually lift 100. You've got to overload that muscle to cause it to adapt to be able to lift 100 pounds. And the same principle applies to bone. If this is the normal range of loading forces that the skeleton is accustomed to seeing on a day-to-day basis, if you want to build new bone mass, then you've got to get higher forces acting on the bone to cause it to adapt to those forces. So there have been some studies in humans where they actually put strain gauges on the bone to measure the forces that are developed during various activities. So walking is not a very good bone building activity because it's in the low physiologic range of stress that the skeleton sees. Similarly, cycling is down in that neighborhood, so it's not necessarily a bone building activity. These activities might slow your rate of bone loss, but they're not going to cause you to build new bone. Now, if we go to something like jogging or running, going up and down stairs, now, depending on how high you're jumping from or how fast you're running up and down the stairs, now you can get forces that are well outside the physiologic range. These are bone building activities, as are jumping, hopping, rebounding, those sorts of things. So this gives you insight into the types of activities that are likely to build bone. All of them have the potential to slow the rate of bone loss. I want to go back to animal studies because this is where we've learned the most about the type of activity that's most likely to be effective at bone. And these are ancient studies by research standards. They were done 30 years ago. And the model for this was the turkey, because turkeys have bones very similar to human bones. So the first thing these investigators did was put strain gauges on the turkey's ulna bone, similar to our forearm bone, and they measured what the normal forces were during turkey activities. So this is sorry about that, this is the normal range of strain in turkey wings. And then what they did was put a pin in each end of that bone so that they could put it in a device where they would immobilize the bone or they could apply compressive forces to it. And using that, they came up with these beautiful data to show that the magnitude of the loading force was a strong determinant of how much increase in bone mass occurred in response to loading. Now, I told you earlier that exercise or loading usually brings about only small changes in bone density. And here, they were seeing increases of 30 to 40% in the range of forces that they thought were normal. So when they looked at their model, they came up with this conclusion. Although the peak strain magnitude was similar in the natural and artificial loading conditions, the position of the neutral axis during artificial loading was rotated by about 90 degrees. What the heck does that mean? Well, let me tell you what it means. Our bones, our long bones, have a natural bend to them. And that's because our muscles pull on bones, and that causes that natural bend. So what they were doing, instead of stressing the bone along the natural bend, that bone was rotated 90 degrees, and they were now bending it sideways. And that's the evidence that if we want to stimulate new bone growth, we have to stress the bone in a way that it's not accustomed to seeing. It has to be a novel stress. And if the stress is novel, then the skeleton can adapt dramatically to exercise. The same model, they looked at how many loading forces they had to apply to maximize the response. This is what happened when they immobilized the wing. For over only 6 weeks, that bone lost 10% of its mass when it was immobilized. They had to apply only 4 loading forces a day. 1, 2, 3, 4. That was enough to fully prevent bone loss. And if they increased, I have 10 minutes, 6:40. I'm looking at the clock. If they did 36 loading cycles or 360 loading cycles, it didn't make a difference. They had maximized this. That tells us that if you're doing the right type of high-intensity bone loading exercise, you don't have to do very much of it. Maybe only a minute or two per day would be enough to maximize the benefit. The loading rate is important. If you do something very slowly, it's not as effective in bone as if you do it, very fast. So high loading rate is important. And here's something that we haven't studied in humans yet, and we need to. If the difference between 36 and 360 loading cycles a day, no different. But what if we took that 360 loads and did it in multiple sessions rather than one session? So if you do 4 sets of 90 or 6 sets of 60, now you can increase bone formation much more than if you only do a single bout of 360. So that says that multiple short exercise sessions per day may be more effective for the skeleton than just going out and doing one 30-minute or one 60-minute bout of exercise. And you'd think with this wealth of information that we have from these beautiful animal studies that we would have come up with a very well-defined prescription for humans. These are the preeminent organizations that make recommendations for bone health in this country, and here is their recommendation for exercise. Regular weight-bearing, balance, and strengthening exercises. That's like if I took a bottle of pills, there's 3 different kinds of pills in here. One's regular weight-bearing, one's balance, one's strengthening. I don't know how many you need to take or how often you need to take them. Just take them. It'll work. We need to do better than that. And in fact, we do have one position statement from the American College of Sports Medicine, and I did have something to do with this one, that has a little bit better prescription. So we know the mode of exercise should be weight-bearing endurance or resistance, weightlifting. We know that the intensity should be relatively high in terms of bone loading forces. And in this article, we put in a recommended frequency and a recommended duration, but I can tell you the first time we submitted this article, we did not include those because we don't have good evidence in humans to know whether that level, that prescription, is either necessary or sufficient. We do know that if you do that volume of exercise, it can be effective, but it's possible that it could be more effective. I'm going to skip through this one because I only have a few minutes, 7 by this clock, on what the contemporary ideas are. And I want to get to this, at least touch on them. So let's go to this non-steroidal anti-inflammatory drug question first. This is important because NSAIDs block the action of this enzyme that produces all these things down here that we refer to as prostaglandins. So when NSAIDs are present, we don't make those substances. And that's important because one of those substances, prostaglandin E2, is essential for turning on the bone formation response. And so in animal studies that have looked at this is an index of bone formation. So when there's no drug present, you get this nice big bone formation response when you mechanically stress the bone. But if this drug, NS398, which is a non-steroidal anti-inflammatory drug, if that's present 3 hours before or 30 minutes before the stress is applied to this bone, thank you, the bone formation response is reduced by more than 50%. Yet if you give that drug after the stress has been applied to the bone, then the bone formation response is relatively normal. So I did the first proof of concept study of this in human beings a few years ago, and we did our first study in young women. So our hypothesis was a lot of people take ibuprofen before they exercise. Anybody in this room use ibuprofen? Oh, I should have brought a survey so I could get some hard data. So we had these young premenopausal women, aged 20 to 40, come into our exercise facility on average 3 days a week for 9 months. And on any day that they were coming into exercise, they took 2 study pills. They took one an hour to 2 hours before their exercise session, and they took the other one immediately after. So they could be in 3 different arms here. They could have taken 400 milligrams of ibuprofen before exercise and placebo after, placebo at both time points, or ibuprofen after. And our hypothesis was that the group that was taking ibuprofen and NSAID before exercise would have the least favorable improvement in BMD, bone mineral density. And that's the changes that occurred at various skeletal sites over the time of the study. Normally, we expect to see an increase in BMD over this time interval of about 1%, which is what we expected in our placebo group. We didn't get this, and we had told these women that they could use Tylenol, because Tylenol is thought to be different from NSAIDs, but there's emerging evidence now that it's more like NSAIDs than not like NSAIDs. So it might be just as harmful on the skeleton. But then our group that took ibuprofen after they exercised got very large increases. In fact, even larger than we expected to see, almost twice the increase that we expected. So that was our proof of concept study to suggest that yes, NSAIDs are important in the skeletal adaptations to exercise. So we then went and did a slightly larger study in older adults, older men and women, 60 to 80 years of age, same study design. This time they told them they couldn't use Tylenol. They had to use ice if they had orthopedic discomforts with exercise. And this time we did get this 1% increase in bone mineral density in response to this exercise program, as we expect to see. And we did, in fact, at regions of the hip, see that NSAID use seemed to prevent that, although not at the spine. And remember, in the young women, when we gave them ibuprofen after, that had a good effect. Not so in older adults. If anything, the use of NSAIDs after exercise, specifically ibuprofen, seemed to be even more harmful. Now, I want to caution you that this is still considered preliminary evidence. We can't make any clinical recommendations based on one randomized controlled trial, but I think it's enough evidence to take a cautious approach for how you use nonsteroidal anti-inflammatory drugs if you're exercising with the intent that you want to get skeletal benefits. Let's go on to the second factor I wanted to talk about, and this is disruption of calcium metabolism during exercise. We got interested in this because of the observation that some athletes, like cyclists, often have low bone density relative to other athletes like runners or soccer players or shot putters. And even when we compare them with control subjects, they seem to have low bone density. And the common belief has been that cyclists and swimmers have low bone density because they perform weight-supported exercise rather than weight-bearing exercise. And that might be, but the fact that bone density is sometimes lower than normal at least suggested to me that under certain conditions, exercise might be causing bone loss. So we did our first study just following a group of competitive cyclists over a year of training and competition. These were young men, 20 to 40 years of age. They shouldn't be losing any bone, and yet their rate of bone loss was similar to what we see in postmenopausal women who have accelerated bone loss. And we've since done another small group of women cyclists and show the same thing. And this is not limited to weight-supported exercise. I'm aware of one study in the literature that followed NCAA Division I basketball players. Basketball is a bone-loading event. But these basketball players lost bone over 1 year of competition and practice, and this is labeled as without calcium supplement. And then in the next year, they gave them calcium supplemented beverages during practice. And they actually showed that in the next year, their bone mass came back up. So our hypothesis on this is, we've got a few, but this is the one we're studying, that athletes who are performing prolonged or vigorous exercise are sweating a lot. And there's calcium in sweat. So we're losing calcium through our skin. And that causes a decrease in the calcium level in our blood that increases this hormone called PTH, parathyroid hormone. And the job of parathyroid hormone is to stabilize your blood calcium level. And one way it does that is by going to the bone, because that's a huge reservoir of calcium, and stimulating the mobilization of calcium from bone. And we suspect that if that happens repeatedly under certain conditions, that could contribute to a decrease in bone mass and bone density. It also suggests that maybe if we provide supplemental calcium before or during exercise, that maybe we could prevent some of these downstream effects. So I'm going to skip, I'm over time now, I'm at my 6:40. I'm going to skip through the slides, the science slides, and I'm going to tell you that we have evidence right now, I'll just use this one, to show that if we provide calcium before and during exercise, we can markedly reduce the increase in parathyroid hormone. And we can also markedly reduce how much calcium is mobilized from bone. We've got a good marker from that. So we've got this evidence that suggests that maybe we should be having people take calcium before they exercise. But I'm going to tell you right now, I'm not sure about that. And the reason I'm not sure, remember that drug I told you to remember? Teriparatide? That is a form of parathyroid hormone. And parathyroid hormone has these very paradoxical effects that when it is elevated chronically, it is extremely bad for bone. But if it's elevated only transiently, like with one dose of this drug per day, then it paradoxically has a good effect on bone. And exercise doesn't cause a chronic elevation in PTH. It causes only these transient increases. But right now, with the evidence we have today, we don't have any signal that it is stimulating bone in a good way, like it does when we give it as a drug. So, wrapping it up, what have I told you today? I've told you that our current clinical recommendations for physical activity to prevent osteoporosis are much too vague, particularly with respect to duration and frequency. But I can tell you that if you do relatively high-intensity bone-loading exercise about 30 minutes a day on most days of the week, that should be beneficial. I've told you that the use of nonsteroidal anti-inflammatory drugs might be harmful. We don't have solid evidence for that, but I think it's enough to caution you that you shouldn't use those drugs indiscriminately. Only use them when you really need them. And I think you have to stay tuned, because in my heart, my gut instinct is that we probably should be providing calcium supplementation to better enhance the benefits of exercise on bone. And the timing of taking that calcium when you're exercising might be really important. So I just want to thank my research group. I want to thank the sponsors who support my research, and I really want to thank the Center for Women's Health Research, not only for this event, but for the many ways they support me. Thank you.
Can you guys hear me? Okay. Thank you, Dr. Court. Thanks very much. So we have a dietitian also here who you guys can ask questions of, but I think that Dr. Court just made the recommendation or supports the recommendation then for drinking chocolate milk after exercise. Yeah. All right, we're going to go right on to our next speaker. And again, questions and answers will be done at the end. We're going to move on to one of my dear colleagues, Dr. Rachel Bracke. She's going to be talking about your core and why it's so important. Dr. Bracke attended Swarthmore College and then at University of Texas for her medical school. She did her residency at the #1 PM&R residency program, Physical Medicine and Rehabilitation, at the University of Washington in Seattle, so she's really smart. And then she did her fellowship with us here at the University of Colorado. She's now an assistant professor of physical medicine and rehabilitation, and she specializes in non-operative management of the spine and sports and musculoskeletal injuries. She also competed in cross country and softball while in college. She has run several marathons and is in the process of returning to road racing after having had 2 kids, some cute kids. She continues to play softball. She runs, does yoga, and enjoys Pilates, and is walking with her family most of all of these days. Please welcome Dr. Rachel Bracke.
So I'm Rachel Bracke. I'm honored to be here. This is a really exciting event. Women's health is near and dear to my heart, so I'm thrilled to just be part of this. So let me just dive right in. I'm going to talk to you about the core. I split my time between the Spine Center here at the University of Colorado and the brand new Sports Medicine and Performance Center up in Boulder, which just actually opened last week. So if you want any information on that, there's some pamphlets out in the back on one of the tables, and I have some cards here. So moving on. So the core. In the center, I said, the more you know. So I feel like this is my personal public service announcement to everybody. This is something I feel very strongly about. It's something I talk to my patients about on a daily basis. And it's something that I think we can really have a huge effect on women's health if we pay more attention to this. The core is gaining popularity. There's Core Power Yoga, which is a popular yoga chain in the country, including here in Denver. We think of an apple core as being the central core from which the apple grows. And I really think of the core being similar to in our bodies. It's a very important central part of our body that makes everything work well together. Now let's move on. So today I really wanted to touch on 4 primary topics. First, I want you to all understand why the core is important, especially for women. It's important for women and men, but I'll really focus on specific issues related to the core for women. Also, we'll talk about how it's associated with urinary incontinence, how it relates to athletic performance, and how it's also associated with back pain. So first, I'd like to define the core. What do we mean by the core? A lot of times people think it's the ab muscles, the six-pack, that's the core. The core is actually much more extensive than that. I consider it to be a box. The top of it is the diaphragm. Then you have the abdominals in the front, and then the paraspinals and the butt muscles in the back. You'll hear butt muscles as a refrain, because it's not something that a lot of people often think of when they think of core strengthening, but it's a huge part of the core. And it's often very neglected, actually. And then the pelvic floor and the hip girdle also. So the pelvic floor is kind of the bottom of the box. And so you can really see that here. So top, the front, the back is right here, including these glute muscles, and then you've got the bottom, which is the pelvic floor and the hip girdle. Okay, so there are lots of different terms out there for core strengthening. I will just continue to use the phrase core strengthening just because it's easier for simplicity. There are a lot of different other phrases used out there in the physical therapy literature and with other different types of providers, but again, just for simplicity, I'll kind of keep it simple. So core stability really requires 3 different features. First, there's the passive feature, and that's the bones and the ligaments. Those are the things that we just learned a little bit about bone health. Those are things that you do have an effect on, but they're over years and decades of behavior. There are some other things that you can control on a kind of more short-term basis, and those are neuromuscular control and active in the core and the spinal muscles. So neuromuscular control. This phrase will come up in my talk and other talks later, and it's a concept I really just want to define for you. What do we mean by neuromuscular control? So I put a picture here of a high jumper. This woman is not able to high jump because she watched someone or read it in a book and then just did it. She had to practice and practice and practice. Even if theoretically she knew how to do it, her body had to learn how to do everything in the right sequence. And so that's what neuromuscular control is. It's putting everything together and knowing how to fire your muscles in a certain way to really get them active at the right time. And so again, you'll be hearing that phrase. And then again, these muscles are a really important part of this triangle. That is core stability. Why is the core important? There is a lot of literature out there looking at the core, and we know a lot about what happens when you have a weak core. And there's a lot of different medical problems that can happen. Low back pain, sacroiliac joint pain, pelvic floor plane, ACL injuries, which we'll hear more about later from Dr. Wolcott, IT band syndrome, ankle sprains, urinary continence, etc. And also there's an association between core strength and athletic performance. So what does the core actually do for us? I think the core as a muscular corset that really keeps everything kind of working well together. And it really connects our upper body and our lower body. So it's a really important network of muscles that keep your body moving in a smooth way. And elite athletes are often elite because this is something that's very well developed in them. And core strengthening is very instrumental both for athletes and for training, but also as a common recommended treatment for a lot of different types of injuries. Why is the core really important for women to consider? Pregnancy. A lot of women at some point in their life become pregnant, and especially during the second and third trimesters of their pregnancy, that core is stretched and essentially damaged. It's not damaged beyond repair, but it's damaged in a way that if you don't address it, it's not just going to bounce back and go back to pre-pregnancy levels. And that's one of the issues that I feel very strongly about, because I think it's really under discussed and emphasized. You know, you have a baby, you're busy, you're recovering yourself, and then people return to work or are taking care of a busy family. And they don't often have the time they need to really get the strength back that they need, but then they're setting themselves up potentially for injuries and problems down the road. So again, this is just a visual of what a third trimester pregnant woman looks like, and you can just imagine the amount of stretch on these muscles. And so what happens a little more specifically during pregnancy is during the third trimester, a gap develops in this rectus abdominis muscle. So the six-pack muscle really gets a gap. And it's actually something you can measure. You can take an ultrasound probe and actually measure how many centimeters that gap is. And this is widened in almost every woman who reaches full term. And the issue is what happens post-pregnancy. And it's very interesting. There's very little literature out there about, if you don't do exercise, will it narrow and go back where it should, or do you need to exercise to get it, and does that have a huge impact on that? We just really don't know the answers to those questions yet, but they're really interesting questions that I think do need to be looked at. And what we do know is there is a link between the abdominal function of the core and that gap. So it's important. So if there's that gap, it really puts the whole core, it's in a compromised position. And again, I just mentioned this, and the gap often is referred to as the diastasis. And I'm sure many of you have heard of this referred to, and it's often something addressed in physical therapy and postnatal yoga classes, etc. Okay, so what if your core doesn't work? What are some of the things that happen? Well, you actually get increased spinal motion. That may sound like a good thing, but this is the kind of spinal motion you don't want. It's the spinal motion that puts your spine in more of a stressful position, which can put your spine at more of a risk for things like herniated discs. Also, you have, without a core, you have poor trunk muscle endurance, poor hip mobility, meaning the range of motion around the hip joint just isn't what it should be. And then gluteal muscle underuse. Really, this is a fancy way of saying a weak butt. And so I apologize. There are not a lot of professional pictures out there for women's butts. I'll just put it that way. I may be losing my job because a few days ago here, I was Googling like search terms like woman's butt, like really strong woman's butt. So we'll just let the IT department know this is for a legitimate reason. It's very interesting to see what you get when you Google those terms. This is the best thing I could find that wasn't inappropriate. So flat butt. Basically, our culture loves small, tiny little butts. And really, we need big, strong butts, and that really should be the goal. And I included this picture because, you know, it kind of shows the difference. This still could be much bigger and stronger, but this is the best I could find, again, that was appropriate. So again, butt, really important. So what should a lady do? What should a woman do if they're in this situation? You know, either they've gotten busy, whether they've had a baby or not, that doesn't always matter. The core is really important. So postpartum, I think what's really important is that core strengthening is addressed. And I think this can set a woman up for much less risk of back pain, injuries, ankle injuries. I mean, there's lots of different things that can be benefited by this. And also, it can get someone, if they're a tennis player, after baby, it can get them back to playing the way they were playing before. And I think the core is really huge there. Okay. So we've addressed one of my 4 topics, and apparently I have 5 minutes left, so I'm going to continue to fly. So urinary incontinence. Again, a lot of these just have a few slides, but I'll talk very quickly. So urinary incontinence, so a woman has a baby, and especially with vaginal deliveries, there's a direct link between vaginal deliveries and urinary incontinence. And that's a pretty high rate. 20% of women are incontinent in the postpartum period. That's not forever and ever, but that's in the 6-month to 1 year post-baby. Weak pelvic floors are the issue, because oftentimes that pelvic floor hasn't been addressed and hasn't been strengthened. And I think really that's important. And there's some Kegel exercises, there are lots of different things you can do that can really help getting that pelvic floor back where it needs to be. And again, that's part of the core. And there's been a few kind of studies out there looking at pregnant women. 2 were split, 2 different groups, supervised pelvic floor exercises with a home program, and another group that just got general information. And the group that got the exercises did a whole lot better. Okay. Okay, so I've covered 2 topics, so we're moving along. So we've talked about why it's important for women. I hope everyone understands that concept. And then also some of the brief kind of connections with urinary incontinence. Now we're going to move on to athletic performance, and this is a pretty quick topic because I do want to spend some time on back pain. So core strengthening and performance. I'm sure there's a lot of active people out there and a lot of athletes. And there have been some studies looking at what happens when you take an athletic group of people, like on a swim team, et cetera, and split them up into 2 groups. One group just does their laps, and the other group does some core strengthening and does their laps as well. And so this study was done with the national junior swimmers. And in this study, basically, the folks who did the core program, in addition to their laps, their swim times improved. Also, there's a study about golfers. And so they found if a person was not able to do a deep squat or a single leg balance on one leg, they were more likely to have swing problems because they're just not using their spine and their core the way they should. And so they're having kind of bad habits develop because everything is not where it should be. So that's another study that was done, just looking at if you have a weak core, your golf swing isn't quite so good. Okay, so that's my brief discussion on athletic performance. And now I will move on to back pain. And I do want to spend a significant chunk of my remaining time on this because I'm aware that there's a lot of people out in the audience that do have some questions about back pain or that's a current issue for them. So back pain is a very common issue. And core strengthening is often prescribed as a treatment through physical therapy, usually, for treatment of back pain. There are lots of different causes of back pain, that's the problem. And there are lots of different core exercises. And so it's really important to have a diagnosis because if you do the wrong core exercise and it matches up with the wrong diagnosis, you could actually make things worse. It can make your pain worse. And so that's one of the things where you really want to kind of consider, and I'll talk a little bit about the different types of exercises available for different types of diagnoses. But again, I think of core strengthening as not a one-size-fits-all type deal. It's something that really should be specified, especially if you have an injury or you have pain. Okay, so there's some evidence out there about prevention of back pain. So there's a group of women, collegiate athletes, and those who were doing hip abductor exercises and had stronger hip abductors. And this picture shows what we're talking about. Hip abduction is this motion. Those with the stronger hip abductors had less of a likelihood of developing low back pain during the season. There's quite a bit of evidence out there regarding core strengthening for low back pain. And core strengthening, really the general summary of the literature out there is it's not great. There's not a lot of solid evidence out there, but I'd say in general it's favorable towards that core strengthening is helpful for low back pain. There was a study in 2006 that split groups into exercises versus manual therapy versus an education booklet. So manual therapy, so one group did core strengthening, another group got massage and got some manual therapy around their lumbar spine, and then another group got just an education booklet. And those who got the strengthening did better. Their pain came down and their functional level improved. Another study looked at hockey players, so a very active group. And this was a national team, so very high level. And they had low back pain, and there are two groups. One group of the back pain hockey players got core strengthening, and the other group got ultrasound treatments, and the folks in the strengthening group did better. So I just want to briefly touch on different very common back problems that are seen in my clinic. So we've got herniated disc, SI joint dysfunction, spinal stenosis, lumbar facet arthritis, and muscle-based non-specific pain. This is probably the top 5 that I see very commonly. Just a brief lumbar spine 101 anatomy lesson. So there's the neck, the mid-back, and the low back. I'm really focusing on the lumbar spine here, which is basically L1 to L5. These are cross-sectional, these are vertebrae, the bones that make up each one of these goes over here. This is the central spinal canal where the nerves run before they travel into your legs. This is the facet joint right here, and this is the disc right there. Oh, and going back, I didn't point this out, but I will talk about the SI joint. The SI joint, or sacroiliac joint, is the junction between the sacrum and the ilium. So the very lowest part of the spine and the pelvis, basically. And don't worry, this is blurry. There is going to be a test later, so I hope you memorize this really quickly. But there's a lot of muscles in the back, and that's the thing to remember. Is we think of maybe 3 or 4 muscles off the top of our head when it comes to the spine, but there's a lot of different muscles, and so muscle pain can be coming from a lot of different potential places and have a lot of different potential causes. So again, going back to the why is core muscle function so important for all activity, we're kind of going back to this triangle here. We used to think that discs had a lot of shock absorption, but they don't. So that's why it's really important to get the neuromuscular control and active part of your core engaged. So let's meet some ladies from my clinic. Yes, okay. This is Grace. She's a 30-year-old who had a new onset of back pain after a tennis match. She has shooting pain down her right leg and into her big toe, and she also has a lot of back pain. So she has a herniated disc. I just happened to make this case up, but I see this a lot. So she has a herniated disc, and there are certain exercises that are really important. And in her case, she should have neutral or extended spine core exercises. So this is flexion of the spine. This is extension, arching back. This is neutral. In her case, the flexion could potentially make the disc herniation worse. So in her case, I would send her to physical therapy, and they would focus on exercises that would be in those planes. So these phrases I'm going to throw around in the next 2 or 3 minutes. So this is the kind of exercise she would get from physical therapy. This is when she gets really good, this is what she would start out with. So basically, it's called a prone opposite arm and leg lift. So she's laying on her stomach, lifting one leg, the left leg, and the right arm at the same time and holding it for 10 seconds, and then switching sides. So it's kind of like a swimmer position. Now we're going to meet Leah. She's a 35-year-old woman who's 6 months postpartum with new onset right-sided butt pain. So she has right SI joint pain. And she needs to strengthen her hip girdle. So the butt. And so what she would do is what's called the wall slide. So you don't see the before picture, but she would lean against the wall and then scoot down and then scoot back up, all while keeping her back in contact with the wall. But that would be the type of exercise that would be helpful for her. Then you've got Doris, who's a 75-year-old woman with a few years of worsening low back pain and radiating pain down into her legs. Pain is worse with standing and walking, better with sitting. She has spinal stenosis. Spinal stenosis is when that spinal canal gets narrowed and it pinches on the nerve roots. So in her, you would want to do flexion, you would want to do core strengthening while she's in a flexed position because that actually opens up the nerve canal and makes it more comfortable for her. This would be the type of exercise that she could do because, again, her spine is getting flexed here, not extended, which would make things worse. And then here's Ellen. She's a 55-year-old woman with low back pain with rotation. So anytime she turns her body, her pain is worse. And it's been worsening over the past 6 months. She has a facet arthritis. The facet joints are on the back side of the spine. She has a little cyst there. That's all part of the arthritis. And in her case, we would do core strengthening in the neutral or the flexion position. So something like this, again, would be the best option for her. Because it wouldn't stress the facet joints anymore. And then lastly, there's Jennifer, 40-year-old woman with low back pain that's reproduced with palpation. She has a lot of muscle tenderness all over, and she has myofascial muscle-based pain. And so it's all over, tender, everywhere I touch. And in her case, she needs a very gentle progression of core strengthening. And then this is the type of exercise that would be really good for her. So kind of on all fours, and then you lift up the opposite arm and opposite leg, and then swap. Okay, so we have covered everything. And if you're motivated, there are lots of different ways you can strengthen your core. There's Pilates, there's yoga, Tai Chi, core classes. A lot of rec centers have core classes. And physical therapy. And I would emphasize physical therapy because if you have an injury, for all the reasons I mentioned before, you really want to make sure you're doing something that's safe for you. And we love releasing you to do your own thing at home and being very independent, but you just, again, if you have an injury, it's probably a good idea to get that sussed out a little bit. And again, lots of amazing women athletes out there, pretty exciting time, but thank you, I really appreciate your attention.
Let's see. Thank you, Dr. Brackey. All right, we're going to move on. Next up is Dr. Michelle Walcott. Dr. Walcott is awesome. She directs our CU Sports Medicine Center and keeps us all doing what we're supposed to be doing. She is an associate professor here at the University of Colorado in the Department of Orthopedic Surgery. She attended the University of Utah for college, Georgetown University for medical school, Loyola Chicago for residency, and a sports medicine fellowship at the University of Iowa. She also takes care of the CU football team, CU women's basketball team, and all the training rooms all the time while raising 2 children, and she's awesome. And she's also has run 15 marathons, I think since I've known you.
Yeah,
Yeah.
since you've known me.
And she's in training for the Twin Cities Marathon, number 16, from Marathon for Her, on October the 4th. Please welcome Dr. Michelle Walcott.
All right, I'm using my own computer, so I'm hoping this all works. You guys can hear me? Good, okay. Yeah, I actually have that marathon coming up, and I was just discussing I haven't done that much of a training plan. I've been running, but I don't really know what I'm doing this time because I've been super busy. So anyway, my talk today is going to be about the ACL, and I titled it From A to L primarily because I think this is really where we are. We haven't solved this. ACLs are very common. We think we know what we're doing. We've got a lot of good information. We're getting good results, but we actually really have a long way to go. And so I don't want us to think this is a done topic. It's actually a pretty exciting topic if you're a surgeon who does a lot of these, which I am. So this is a very, very common injury. I'm guessing if anybody show a raise of hands, either had an ACL surgery or knows someone who's had an ACL surgery, it's dominant in society. It's roughly 1 in 3,000 people, or over 200,000 surgeries per year. That doesn't even count the people who don't have surgery, so it's extremely common. Women are up to 8 times more likely to tear their ACL, and you guys have probably heard this. As women, we hear this. It may not be quite that high, but it's certainly much more common than it is in men. And the mechanism of injury can vary quite a bit. Most of the time, we think of cutting, pivoting, landing, like jumping or rebounding, decelerating, coming to a stop. Hyperextension, we see that sometimes in skiers, which also goes along with pivoting. And actually, it's not that common. We actually see the contact injuries, although we see those in things like football, sometimes skiing, contact with a person or a tree, or a snowboarder, which is really the most common. But this is kind of what it looks like after it happens. Ow, ow. They always grab their knee. This is actually one as it's occurring. So you can see this is how she landed. This is kind of what happened. And I'm sparing you the video of that. I actually had some video that's not going to work, so you don't have to watch it. You're welcome. The ACL itself, I'm going to go into a little bit of definition. I think most people have a pretty good idea of what it is, but I think how it functions is not always clear, and maybe not even to me. But the ACL is a cross-linked structure. It comes from the outside of the knee or lateral on the femur, this bone, to the medial side of the tibia, but it also comes from the back to the front, and it forms sort of a cross with the PCL. And those two work together really to control rotation more than anything else. We think of it as sort of a front to back ligament, but it really is more of a rotational ligament. Why does it tear? This is in men and women. It's relatively small. It resists motion in multiple planes, so it resists that forward and back motion, but also that twisting or rotating motion. One of the things we don't think about so much in society, but I think about as a surgeon, it lives in a pretty avascular environment. There's not much blood supply to the ACL. There's one artery in it, and once it tears, it doesn't really reestablish anything. A clot doesn't really form here, and the fluid in your joint, which is what lubricates your joint, washes away anything that tries to heal there, and that's why they don't heal. But the biomechanical stresses on the ACL are probably even more complicated than just these two motions, and I think that that's why we have so many varieties of types of injuries or how these occur. So why does it tear in women? Well, there's certain obvious things. We have estrogen receptors actually in our ACLs, probably realistically have them everywhere, but also in our ACL that men also have, but they aren't as sensitive to it because they don't have as much estrogen. The ACL in women is a smaller ligament just because in general we're smaller. It exists in a smaller notch, so it's a relatively small ligament in a smaller area. That notch can sort of pinch or impinge really the ACL. Valgus alignment is more prominent in women, and this is sort of a demonstration of what that means. So if you see on the right side of the slide, the knees kind of come together. They're inside of the plane of the hip versus varus alignment, or where the knees come outside the plane of the hip, and we have wider hips, so that's why that occurs. But we heard this talked about earlier in the core, but neuromuscular firing is important here too. We have a lot of muscles that balance our knees. Primarily, we think about the ones in the front and the back, which are the quadriceps and the hamstrings, but also the butt. We're going to come back to that. It keeps happening. But in women, we don't fire them at the same time. We're not weaker necessarily, although sometimes we are, but we don't fire our quads and our hamstrings in the same phase as men do. And you see that when you see what looks like an athletic-looking woman versus a woman who looks sort of awkward, or even a man, but it's more common in women to see that. But what happens when it tears? Those of you who had this happen probably are very familiar and may not want to relive this experience, but sometimes you feel a pop. Usually it's some sort of twisting. Most of the time it's when you stop or turn or land. But the knee rotates or pivots over the central point. I'll sort of demonstrate that again. You can sort of see it. Sometimes you have swelling, sometimes you don't. That's not a very good sign. I call it a positive toboggan sign if you can't get up and ski back down the mountain. It's not 100%, but it's usually pretty good. But here's what it looks like on an MRI. So from a structural standpoint, this is the only one on this picture that's intact, and it doesn't look like that much. It's these lines that sort of look like they're under tension. They're straight versus this wavy appearance where it's ruptured. Sometimes they look like this, where you see some ACL here, but you don't see anything on the femur or on the thigh bone area where it attaches. And most of the time you see this. It's just a blob. It doesn't look like anything. And that's what it looks like in surgery as well. I put this picture up there just to orient you. This is a side view of the knee. So it's sort of looking at the side plane of the ACL, which is from back to front. But this is actually what really happens, and we see these bruises on an MRI too. This is also the side view, but now we're looking really at the outside of the leg, right out here. And what you look at when you see this is that the bruise on the femur is pretty anterior. It's near the front or even really the middle of the femur, but it's in the back of the tibia. And so what happens, this is just cut this out and align those bruises together. This is actually sort of a mock-up of where the ACL is. But in order for this to hit that, you have to rupture your ACL. So we see this bruise, we know that ACL is torn because you can't get there from here. So why is the ACL important? Well, any of you who've had one probably have a pretty good idea why it's important, because it really doesn't feel good when your knee does this every time you try to exercise or cut or pivot. Sorry if that was a little traumatic for you guys. But it's also important because when that happens and your knee gives out, those bruises that we looked at also damage the cartilage. We don't always see it. Sometimes you don't see it for years. But it's protecting the meniscus, which is sort of the rubbery shock absorber, and the cartilage onto the end of the bone. And when those go away, that's arthritis. So it is important to have a stable knee. This is sort of an advanced case here. This is someone who had an ACL reconstruction. They're starting to have a little bone spurs both on the inside and the outside. I know it had an ACL because I see metal in the knee. It's my clue. This is what it looks like in surgery. So if you sort of equate what this looks like arthroscopically to the MRI picture, it's just this blob, a stump of nothing, sometimes fibers that look like that. This is what we do when we reconstruct it. So we take all this out, we just make a new one. I say it like that's easy, but technically that part is pretty easy. We take it from something else or sometimes from a cadaver tendon or whatever. There's multiple graft choices, which is an entirely new, complete talk, but we make a new one because we can't repair it. And then we secure it with either screws or sometimes buttons, sometimes staples, sometimes posts and other kinds of hardware. So this is kind of a nice little adaptation of what that looks like. So here's that ACL blown out. There's nothing there. This is actually a real graft laid on top of an X-ray to show you that's the graft part. This is a patellar tendon. So there's a little bit of bone here, a little bit of bone there, and we actually secure it with screws on either end. So that's your 101 of the surgery. You guys can all do this now, right? I have a few tomorrow if anybody wants to do so. But what's the natural history? What's interesting about this, as I pointed out, is that the ACL injured knees, and this is in multiple studies, but has been shown almost uniformly, has an increased rate, up to 10 times increased rate, of developing osteoarthritis compared to an age-matched, uninjured population. What's interesting about this, that's whether or not you have surgery. So we may not be solving arthritis with surgery. But what we want to know is why. We think we're doing a good job. Why is this not working? Well, this is a study, actually a systematic review, which really looked at a whole bunch of other studies. That's what a systematic review is, and compared things that they had in common, taking out some of the things that were sort of they were confusing details. They didn't really average out what was mostly happening, and took the things out that it had in common to come up with essentially what does our literature show us currently. At about 14 years after an injury, patients who had ACL reconstructions had less meniscal injuries. We expected that because they weren't pivoting, they weren't twisting. However, and they also had less need for further surgery, usually meniscus surgery or sometimes tear of the ACL, and better activity levels, because if you can imagine, now you can run and jump and pivot without your knee giving out. But at 14 years, they did not have an improvement in radiographically evident arthritis, so they were still getting arthritis, and they really didn't have that much improvement in their satisfaction, which, that's what we're really measuring. It's not so much, did I do a great job in the OR? It's really, is my patient happy? Well, they're happy if their knee doesn't give out and they can do activities, but they're not happy if they're developing arthritis 15 years later. So what we did is we joined this group about 13 years ago, the Multi-Center Orthopedic Outcomes Network. We call it MOON. You may see that if you're looking at any type of orthopedic literature because it's been a huge database collection of all sorts of ACL reconstructions all over the country. These are the academic centers that are involved. We've been involved here since the beginning. I've been involved with it since the beginning. It's sort of housed here at Vanderbilt where they're collecting and storing all the data, but we've published a bunch of studies out of it. So what it is that we enroll every patient who has an ACL reconstruction. We're not currently enrolling, so if you had one recently, you may not have been enrolled. But we enrolled everyone who had an ACL reconstruction at these centers, and we asked them to fill out a 13-page questionnaire, which is a pretty long questionnaire. However, I filled out a 30-page questionnaire on my end, and basically what I filled out was, what was the surgery I did? What did I find? Were there cartilage injuries? Were there other ligament injuries? Anything I could find that I could detail, and then how did I do the surgery? How did I fix it? What graft did I use? All of that information. And then we contacted these patients at 2, 6, and we're just collecting some 10-year data now, and asked them to fill out the forms again, because we want to see what happens at 2 years out, what 6 years out, at 10 years out, and we'll keep following this. I don't know how far we'll go, but as long as we can. And it's been a pretty impressive study thus far. We've enrolled 3,200 patients, roughly. We have a follow-up rate of over 80%. I put 80% because this is the minimum we'll accept. If we don't have 80% of follow-up in any group, we hound them, we go after them. I've made lots of phone calls. My partners have made lots of phone calls. We send them gift cards, we drive to their house, whatever. We want 80%, because that's gonna make our data good. We've published 41 studies so far. There's several of them still in the pipeline that'll come out in the next year. Of this group right now, we're at about 44% women, which is really interesting if you realize that we are seeing a lot more tears in women. Right now, our database is only collecting about 44% of that are women. So either they're not having as many surgeries, or maybe we're operating on less women. I don't know. I think that that's a question I have about where this is going. But what have we found out so far with this data? This is just summary, because I could go through all 41 papers if you want, but I'll simplify. Basically, our average age of our patients is 23, pretty young. At 6 years, our average rate of subsequent surgery on the same knee is 19%. That means any surgery short of a knee replacement. So if you have meniscus surgery, scope, clean out scar tissue, if you re-tear your ACL, about 20%. At 6 years, the average rate of subsequent surgery on the opposite knee is 10%. That was interesting. I don't think we really expected to see that. Of that 10%, in total 10%, 7% of those are ACL reconstructions. So there's probably something in here where these people are at risk. And maybe we need to identify why they tore their ACL in the first place and maybe prevent them from tearing the other one, because that's not a small number. If 20% have any surgery and 10% is mostly ACLs. And what are the risk factors for subsequent surgery so far? If you're younger, you're more likely to have more surgery. I think that sort of makes sense. If you're younger, when you injure your knee, your chances of having complications related to that or needing something in the future are probably just higher, because you're going to live longer. And cadaver grafts, we actually have seen a much higher rate of failure in cadaver grafts than in autografts or from yourself. But we see those primarily in that younger age group. So cadaver grafts in patients who are older or less active don't have a high failure rate. They have a very similar failure rate to autografts. So I do use those typically in older patients. But in a teenager, you would really have to talk me into it, and there'd have to be some compelling reason to use a cadaver graft, because it's about 35%. It's pretty high. So also, we found that women are not at increased risk for subsequent surgery. So if you have your ACL reconstructed, you're not more likely to have another surgery than any of the men at the same rate. And that weight and BMI is not a risk factor for subsequent surgery. So it's not related to that. It doesn't seem to be. So maybe that arthritis or the meniscus tears or other symptoms are not really related to weight, but condition of the knee. There's something that happened when you injured it that probably is predisposing you to having other symptoms or surgeries or arthritis down the line. So really, I want to point out what's most important to me in this talk is that the value of these outcomes registries. Essentially, what we've done is recorded every single patient we did surgery on in those years for ACL reconstructions, which is a high number. What we'd like to do is do that for everything. But it's a huge amount of data to be collected. It's a huge amount of important data to be interpreted. But it's really expensive to do this. I mean, I can tell you just in manpower hours, to get kiosks or to get internet service or to have secure those things so that patients can send them back, to have them come in and stand there at a kiosk and fill it out, to have manpower to enter the data. I mean, you need a whole army of people just to enter it. So I think with EMRs, we're going to be able to do this a little bit better, but I think that really what I'd like to see is that these outcome registries become the standard of practice. And we're starting that here. The orthopedic department this is a top agenda item for us to just enroll all our patients in just outcome registries. We're not asking any questions, we're not doing any studies, but we want to be able to go back and get that information. So future studies from the MOON database, these are the things I really want to know. These are the things I'm really looking at now. What about this age as a risk factor? Well, we know that if you're younger, you're more likely to have more surgeries. What if you're older? I'm like, well, if you're less likely to have more surgeries, maybe I should think about doing this more in my older patients, especially patients who tell me that their symptoms or their knee gives out. It's not that they're unstable, or that they're having pain, it's because they're unstable. That's a really good indication for an ACL. I think I'm solving that problem. I don't know if I'm solving arthritis, but if I do an ACL reconstruction in someone who's 50, I'm not sure they'll get arthritis before it's too late. And if they live a long enough life, maybe, but if you're 20, I know you will. So I think age as a risk factor is a really interesting question, and not looking at the younger patients, but looking at the older patients. How about arthritis as a contraindication to doing an ACL surgery? To me, that's sort of similar. So that if you have arthritis already, but your symptoms are not arthritic, I see it all the time. X-rays, MRIs show arthritis. My patients say, what? I had no idea. Well, just ignore the X-ray. I mean, it doesn't matter what your X-ray shows. How do you feel? So if they don't have symptomatic arthritis, I think that's probably reasonable to consider doing an ACL, and that's what I want to get out of the database. Patient satisfaction expectations, I think that goes to these top two, very much so. And then I also think living here in Colorado, my population is different than all of my partners that they're collecting data in Ohio, Tennessee, Missouri. I think their patients are different, and I think that the patients here are going to give me a lot more information about picking patients based on their activity, based on their health, not based on their age, and not based on their weight even, so we haven't seen that as a significant risk factor. But let's talk about risk factors for a quick second. Some of them are modifiable. Here I have a hard time convincing anybody to not do the activity they love doing. I would not want anyone to tell me to stop running. So if you're going to tell a patient to stop skiing, that's not the answer we want to give them, although that's an answer. I think this is really where we want to focus. Can we make them better, stronger, less likely to injure their knees? This is really what we want to modify. And obviously there are non-modifiable risk factors like age, gender, and hormonal. I don't really want to talk too much about this. I think this is something that may or may not be important later, but I'm not sure we want to put everybody on hormone replacement or birth control in order to prevent ACL tears. It's probably not realistic. I don't know if this video is going to play here. Maybe I'll have to do it here. What I want to talk about with the risk factors is it coming up here? Let's see if it'll play. Okay, so this is a gender difference video. This is my son on the left and my next door neighbor on the right. They're the same age, and when they jump pretty similar for the most part. Don't make any comments about my awkward boy. He's just a boy. But at this age, they look very similar. And when kids, especially girls, start going through puberty, they start to look different. So if we can get kids at this age or maybe a little older and start teaching them programs early on, maybe we can prevent some of this stuff from happening. And I'll show you a couple examples of that. We'll go back to this training, or this picture of neuromuscular training. We want you to land like this. We don't want you to land like that. That's ugly. It doesn't look good. Your butt's way in the air. Your knees are crashing together. So you're absorbing some stress. Look at this butt. If I could see the butt on this, but again, I can't do that either, Rachel. Don't let me do that. This is that girl we saw before when she landed. This is actually the whole sequence of the video. So she goes up and she rebounds. She comes back down. She lands on this leg, and she goes to change direction. As soon as she hits, her knee crashes inward. That's where her ACL tore, right here, and right here. This is actually sort of a similar thing, showing you from the front what that looks like. You jump up for a rebound, you come down. She's not even changing directions, but look how her knees, they touch each other. It hurts me to look at it, frankly. But don't watch me jump. I'm not any better. I just don't play basketball. This is the same thing. So look at how this person lands, knees crashing together. When she comes down, her butt's way up here. This is a much better pattern of landing. Her knees come down, they're wider, her butt's lower. This is a much safer position. So we want to turn this person into that person. This is a video of one of, actually she did tear her ACL, and we put her through the ringer to get her back. But this is one of our University of Denver athletes who learned how to jump. Thought she learned it when she was 5. But look at how nice and wide her knees are. Her butt comes down. That's a good landing. That's a soft landing. She's absorbing impact. And then look at the girl right after her. I'll tell you, she hasn't torn her ACL yet, but if it happens, I won't be surprised. Warning if this is disturbing. It disturbs me. All right. This is actually one of the things, going back to the butt, this is what we want to train. I don't want to see anybody looking like this when they do a one-legged squat. Watch her knee. She does it a few times. She's trying to go down and hit the stool that's right behind her. It gets worse. No, wait. I'm just kidding. But no, really, it will get worse. When she goes to the other side, she almost falls down. Now, I know this girl, if she keeps doing this and she keeps running like this and landing like this and her biomechanics continue to look like that, she's at risk for all sorts of injuries, actually, not just ACL injuries. And those are things we can teach. That's what our team of therapists teaches. We stand in front of a mirror, jump and land, make that look better. This is sort of where the future is going with ACLs. There are whole topics about biologics. Dr. Pasquale is going to go over some of the things we're looking at in terms of PRP, stem cells. This is a scaffolding where you could inject cells onto this, lay them on the ACL. Maybe we could get the ACL to heal someday. There's actually some really good data on this in Boston Children's. And I'm going to do this again. This is a different one slightly, because I wanted my son to look a little better. Yes! They have no idea I did that. I had to ask my neighbor's permission. So outcomes. Basically, what are we measuring? Are we trying to prevent this? Are we trying to make athletes look like this? Are we trying to do this? Get these people back to playing tennis? Look at that. Or do we just want to say, good job, surgeons, you're doing great? No, I mean, all these things, actually. I think this is all what we want. And I just want to say a word about this. This is my life. I'm a surgeon. I'm a single mom. I run. And I have the best nanny in the world. She'll make me emotional because I could do none of this without her.
Thank you, Dr. Walcott. Okay, it is time to get this party started. I need everybody to stand up. We're going to see if you've been paying attention. Everybody up. All right, so a lot of times when I'm talking to people who come into my office and they have back pain or they've injured themselves or their knee hurts,
No. You want me to?
it's often
Sure,
how they're
shut it down.
moving. And so when Dr. Brackey was talking about neuromuscular control and how people are landing, we're gonna just check out a couple things here. And then Dr. Pasquale Garrido is gonna explain some things to us about the next most important joint. All right, so real quick, everybody put your hands on your hips. Okay. All right. I don't see anybody with their hands on their hips, and this is why Americans suffer from back pain greater than anybody else. Michael Torpy's got it because you were in my session 2 days ago. Okay. Okay. So a lot of times when we're moving, we are moving from, you just put your hands on your waist, which is L4-5. So right above that iliac crest is where your lumbar spine is, and that's why everybody has pain in their low back, because this is where we initiate all of our movements from. This is how we pick up our laundry. This is how we load the dishwasher. This is how we put the turkey and get it out of the oven. It's how we put the kids in the playpen, how we get the car seats out. It's all moving from here. So if you want to never have back pain again, you're going to develop your core strength. We're going to use your butts. We're going to develop butts. We're going to do body squats. Maria should be up here. Get up here. Come on, Maria and Lindsay, our physical therapists. So you're going to use your butt. You're not going to do this anymore. You're not going to do this to make your bed, right? You're not going to do this action. You're not going to vacuum like this. You're not going to do anything like this anymore, right? You're going to do everything like this, okay? Butts down, and you're moving from your hip joints. Ooh, ow. That hurt. So anyway, so don't leave. So your hip joint is actually way down here. So move your hands down and find where that ball and socket joint is, way down here. This is now where you will initiate all movement. When you sit down into your chair right now, you're gonna take your butt back and sit using your hip and socket, and you will never have back pain again. Right, Dr. Brackey? All right, so now you can sit down. I'm watching. Our next up is going to explain why you can use your hip and why it's a good joint. If it's designed as a ball and socket, your spine is not designed as a ball and socket. So if you need to get up, down, over, whatever, use your hip. And then you can develop your butt. And we threw in a why you need a butt handout. Let's make sure everybody has that. Okay. Dr. Cece Pasquale Garrido is an assistant professor in orthopedic medicine. She's an expert in sports medicine in the hip. She trained in Buenos Aires, Argentina for college and medical school. Then she attended Rush residency in Chicago for orthopedic surgery. She then completed 4 fellowships, one at the prestigious, renowned Hospital for Special Surgery in New York City and Manhattan, and she completed 4 fellowships in cartilage and basic science research and hip specialty surgery. She is also a competitive marathon runner for the Boulder Track Club. She started running in 2007 and was previously a field hockey player. She has an identical twin sister, which I think is cool. And she placed 3rd overall in 2014 in the Steamboat 10K, and 4th overall in the Denver Half Marathon. So please give it up for Dr. Pasquale Garrido.
Thank you. Hey. Can you listen to me? Yes. I'm very excited to give a talk to so many women together because I'm an orthopedic surgeon, and normally in all my talks, they're all men. So this is very exciting for me, and I want to thank all the hard work that they put together to make this event really nice. So the talk that I'm going to give today is I have been diagnosed with early osteoarthritis. Does this mean the end of my active life? So osteoarthritis is a very prevalent disease. It affects 27 million adults in the United States. The prevalence increases with age, and is affected by obesity and lack of physical activity. So what you see here is basically the cartilage. It's a nice and smooth tissue, and if you see it microscopically, it has a great amount of water, so it allows you to have good compression. But unfortunately, the cartilage tends to degrade when you become older, and then the subchondral bone that you see there try to make the cartilage job, and it cannot do it. So basically, the patients start to have a lot of pain, swelling, stiffness, and limited range of motion. If you see here, the incidence of osteoarthritis is more prevalent in women compared to men. And if you see this number, there's a steep increase on the incidence of osteoarthritis after 45-year-old. So everybody here that has more than 45-year-old, they're probably starting to have some degenerative tissue or cartilage in the joints. So one of the questions I have when the patient comes to my office and I tell them, you know, you have early osteoarthritis, the first thing that they do is, why do I have osteoarthritis? And that's a very hard question for me to answer because we haven't found as scientists the real cause of osteoarthritis. We have seen there are some things that you can associate with osteoarthritis, and if you see in every joint, in the hip, in the knee, it's basically the age. The age is a really risk factor for osteoarthritis. Being a female, the physical activity, having high bone mass index. So all these things are related. In patients that come to your office and you see this, you have to think, yes, that's why probably she's having osteoarthritis. Another thing that I tell to my patients is what information you carry in your cells. And this, we are talking about the DNA. So if you see in these pictures, the information that this family carries is not probably the information that this family carries. So if you see here, you see that this family probably have information in their genes that are telling them to be a little bit obese and have osteoarthritis. If you see this picture, these amazing athletes that are running 2 hours marathon, they're probably sharing some genes. And you can see it. See here, they all have long legs, they have a short torso, they are lean. There's something going inside these people. The story about this is the father and this is the son, and they have both achieved the same. They have both been captain team in the Milano soccer teams, that is a very popular team in Europe. And you have to think that you have to dream what you want to do, but you also have to carry the information to achieve what you want to do. And if everybody is more interested about the sports gene, you can read this amazing book that tells a little bit why these athletes achieve these great things. And at the University of Colorado, we are actually developing what is called a biobank. So basically what we are doing is obtaining synovial fluid from patients. And this synovial fluid will give us information of the genes that these patients have and the proteins that these patients have. So basically, what we are trying to see the expressions of genes and proteins that the patients have in early osteoarthritis and at the end of the disease. So what I'm trying to tell you is that the treatment of osteoarthritis will totally change in the future. We are actually trying to cure a disease that we cannot. And I believe that this is because we are diagnosing osteoarthritis very late. We are diagnosing osteoarthritis when the patient has clinical symptoms and when we see it on an X-ray. We should be diagnosing when these patients do not even develop osteoarthritis. So in the future, probably in 10 years, what we will be doing, you will come to my office, I will do a blood sample or a synovial fluid sample, and I will tell you, no, you have 3 genes for osteoarthritis. Let's try to treat you. So the future of osteoarthritis is not treatment, but prevention. So one of the things is patients come and they say, well, now I have osteoarthritis, what should I do? And sometimes I feel very disappointed when I hear that they've told them, well, wait till you are ready for a hip replacement or a knee replacement. I think that's very unfair. We are treating patients between 40 and 60-year-old. You want to be active, you're independent, your children are grown up. This is the time you wanted to enjoy. So I always tell you have to be active against osteoarthritis. You cannot lay on the sofa and wait for the hip or the knee replacement to happen. So I tell them, let's start the bridge therapy. And this is a therapy that we are developing. Basically, it's the bridge you're going to have between you are healthy and after you need the knee or hip replacement. And we are working on this. And basically, there's a lot of things you can do to start to feel better, even if you have early osteoarthritis. And it's being active, you can take vitamins, bicycle supplementations, and biological therapies. One of the things that is now to become very popular in preventing osteoarthritis is the fish oil. So if you do in vitro studies, the fish oil basically inhibits inflammation, which is synovitis that you see here, and it also prevents cartilage degradation. So the studies have shown clinically that if you start taking fish oil, you will reduce the intake of NSAIDs because it has an analgesic effect. Unfortunately, we don't have any level 1 study proving the success of fish oil, but I normally tell the female over 40 to start taking fish oil. The other vitamin that we have been working on is the vitamin D. So this study started with NFL players back in New York. Basically, the NFL players have a high incidence of low levels of vitamin D. So we started to think, okay, is this putting something wrong in the musculoskeletal system? So we did this study, which was actually very interesting, the study we actually did in rats. And basically, we put a group of rats normal, and the other rats were in a vitamin D deficiency diet for 6 weeks. The only way to get this is basically you put the rat with no light in any specific diet. And if you see here, this is a cartilage, this is a femoral condyle of the knee. This is a staining that you use to see how the quality of your cartilage is. And basically, when you see red, that's very good. It means that that's a cartilage that is healthy, has a lot of proteoglycans, sugars, water, whatever you need to have there. And you can see in the study group how the cartilage starts to degrade if you don't have good levels of vitamin D. And the thing about this is that more than 70% of women between 50 and 70 are not getting enough adequate of vitamin D. So I normally also tell my patients, if you're over 40, start taking vitamin D and calcium. This probably is going to help you with the cartilage. Another thing that we use in patients with early osteoarthritis is viscose supplementation. And basically, this is basically putting hyaluronic acid in your joint. So when you do that, you basically lubricate your joint. It becomes smooth and nice. You gain, again, range of motion. The pain normally is reduced. And what happens is, not only you are lubricating the joint, but we also have seen that what you see here is the hyaluronic acid you put. It binds into receptors. These are the cells. And they are giving information to the cell to become healthy and start to produce some proteins. So this is another way of making you better with your joints. What we are actually doing with patients with early osteoarthritis is the stem cell therapy, or what is called bone marrow concentration. And this started earlier in the horses. So the horse is a great model for us to know if that will be successful in the patient. And basically, these horses that we normally treat are high-level athletes. These are horses that are racing constantly, and they develop osteoarthritis the same way we do. And when we started putting stem cells in these horses, they were back racing amazingly. Actually, right now, we are doing some research study in horses using stem cells. And why we are using the horse model, this is the best model because of different things. If you see here on the left, this is an arthroscopy in the knee of the horse. So it's exactly the same like we do in our patients. And what we are doing there is basically here inoculating stem cells with a hydrogel, and we are proving if this is really successful. The other thing about the horse is not that they not only has cartilage and subchondral well exactly like we do, but you can put the horse in a specific post-operative protocol of PT. You can see how the horse do the treadmill here. If you try to do it in a sheep, it will never do it. They don't like the treadmill. So that's why we are doing all this research study in the horses. So basically, how do we obtain the stem cells? We do a bone marrow aspiration, like you see here. This is an outpatient procedure. The bone marrow aspiration takes like 5 to 8 minutes. once we obtain the bone marrow, we are going to do a centrifugation of that. And that will allow us to obtain not only stem cells, but only a great amount of proteins and growth factors that will help you to become better in terms of the cartilage. And you see here I'm inoculating a stem cells in a patient, and basically you have to do some range of motion, and the patient goes home, has normally 24, 48 hours of kind of easy life, and then is back to normal activity. One of the questions I get when I offer these therapies, what is the research about this? And this is a study that is coming out also from us, and basically there are 15 studies out there showing the success of stem cells. And basically the stem cells are used in osteoarthritis and focal chondral defects. These are all studies that are prospective and retrospective. However, there's a lot of things that we still have to know about this. Basically, the number of injections, we don't really know if we only need one injection, if the patient has to repeat this injection at 6 months or 1 year. When we indicate this, I normally indicate it only when it's an early osteoarthritis. So there's still a lot going on with research on stem cells. This is actually a patient that I did. She's a 64-year-old female. She came to my clinic diagnosed with early hip osteoarthritis. She was very frustrated because she was not able to enjoy her granddaughter. She was not able to garden. She was having pain with daily walking. And I said, okay, why don't we try stem cells? And 3 months later, she sent me this picture, and this was the first triathlon she competed after stem cell therapy. So in conclusion, osteoarthritis is very prevalent in females over 40. There are multiple non-operative treatments that can help you to keep active and improve your symptoms, and always, always be active against osteoarthritis. Thank you very much.
Thank you, Cece. All right, she's a rock star. Okay, so the next thing we want to show you is just more about what the great University of Colorado Hospital does for people. It's funny to think about a hospital, or University of Colorado Health, as we're now called, being proactive and forward-thinking. But we're really excited as physicians to get to work here, because a lot of the folks who are in the audience and kind of in the background make all of the work that we do possible by creating the facilities. And I mean, everything we do, we wouldn't be doing it if it wasn't for the hospital and University of Colorado Health. So watch this video clip. now you get to have the fun. So the fun is getting to talk to and ask any questions you want of our panel members. Please come on up, panel members, and have a seat. And I want to also introduce you to Maria Borg. She is the supervisor of physical therapy at CU Sports Medicine. She's also a competitive recreational road cyclist. Didn't your team come across the Iowa RAGBRAI ride first? So she can really ride a bike. And also Amanda Turner. Whenever I give a talk, all questions lead to nutrition. It's really the essence of sports performance. So if Amanda Turner can come on up, she is the nutritionist and registered dietitian at the Anschutz Health and Wellness Center. Hey, Amanda. All right, questions. It's open. Yeah. Oh, do we have a roaming mic? Okay, there we go. Roaming mic. Maria, how do you get a big butt? And also, one of the things I would say is that a lot of women who come and see me around age 40 or 50 come in and say, look, I'm doing the same workout program and I'm not getting the results that I used to get, 2 years ago. What's up? And so one of the questions is, well, are you strength training? Because as we get older, just because of age, our muscles start to shrivel, even if you're doing cardio. So unless you're doing something to strengthen those butt muscles, the ones you had when you were 20 are fading. So go ahead, Maria, how do you get a butt? And it doesn't have to be big, right? It just has to be functional.
Hello. I'm just going to say something really quickly. The fact that you asked that question makes me really, really happy. As that means we got our point across, so thank you.
I love the question too, and I'm going to say one thing. I have a current patient here that I saw, so Barbara, stand up. Every person that comes to see me in physical therapy, she has an ankle fracture, and they get core exercises. So if you come to physical therapy, you're going to get some sort of core. And I can send some handouts, but basically the functional things are doing
Show us, Maria. Stand
doing
up.
squats like we just talked about, and Dr. St. Fard demonstrated, so you don't need any equipment. We do core exercises, and I will demonstrate a couple, but on our handout here, my colleagues, there's 3 of us here right now, and all 3 of us teach 2 Pilates classes and a core exercise, so the information is on here. So if you want demonstrations and participation, come to the class. It's $10, super cheap. It's a self-pay thing. You don't need insurance. But, big bang for your buck, shall we say, is doing the squats where we're keeping hips, knees, and ankles lined up. Our butt is always behind, our knees are always behind our big toe, so we don't get any injuries. There's a lot of exercise of correct form with lunges, both forward and backward, and that way you're working on balance activity, you're working on strengthening, you're working on coordination, but most of all, you're getting a nice, healthy, big butt.
And one of the things I taught my kids when they were little and started jumping off the porch and jumping off of heights and things was to land like a frog. Okay, so you're keeping your butt back, and none of this, none of that, because that's your ACL, right? Yep. That was scary.
And I'd also like to add, I see some other people in the audience, and people that come to these things are really informed, and I coach a lot of the kids, and I care about each one, and I think if you have kids or grandkids, you start them also in a strengthening program, and so now for us, this seems obvious. This is what we do, this is what we know, but a lot of people don't, so encourage your coaches and your gym teachers and your healthcare providers to get in some sort of program, if not physical therapy.
Yep, and Maria also has classes teaching girls and teams, volleyball players, basketball players, how to jump. So they take them systematically through, filming them when they're doing what they do normally, and then training them, and then showing them their own before and after. So that's happening at, you took a whole class. My kids were in it 3 years ago. So the younger, the better. Get them in.
Dr. St. Fard,
And
we've
you
got a
can
question.
tell from an early age too. I also coach Girls on the Run, and these 2nd graders, 3rd graders, you teach them once and they know it. We got to learn early.
We've got a question right over here.
At what point do you treat with the osteoporotic drugs? Is it at osteopenia, as soon as they drop, the bone mass drops below, normal?
You noticed on my first slide, the initials after my name were PhD. That PH stands for fake. I'm the fake doctor. The rest of my colleagues here are the real doctors who should answer that, but I'll take a first shot at it. It really depends on a number of factors. It depends on your age, it depends on how active you are, it depends on what your bone mineral density is. And there's a calculator tool that's called the FRAX tool, F-R-A-X, and you can Google that. And you can put in some risk factors and get an estimate of what your risk for incurring a fracture is. And your doctors will use that information to decide whether or not you should go on drug therapy. I did have an email message that I got just earlier this week from somebody in Michigan who, she gave me her medical history. Her T-score was minus 3.5, but she doesn't want to go on drugs. She contacted me to find out how she could exercise to avoid going on drug, and my message to her was, the exercise isn't going to do it at this point. If you really want to prevent fractures, most of these drugs are very low risk. There are some serious side effects that can occur, but they're rare in most cases. So even considering whether to take the drugs for a period of time to get a boost and then get more religion about exercise, there are some situations where you really need to go on pharmacologic therapy, on drug therapy, to make sure your bones stay strong. Exercise can't be a cure-all for everyone. Real docs.
Well, a real doc, but if you see me, it's too late. Usually, as a surgeon, I'm fixing the broken bone. But I also just want to make one comment about stress fractures. We didn't talk too much about that, but those are a hallmark too. If you've suffered a stress fracture, you're having bone pain, that can be a hallmark of early osteoporosis, or maybe even later hallmark of it. And I would encourage, since again, we aren't usually the ones who are seeing that, we're usually seeing you once the injuries occurred, that be an advocate with your primary care physician. I think that there are recommendations about when to start screening for that. And certainly if you have any of the hallmark things like compression fractures in your spine or history of stress fractures or something like that, to really be proactive in asking those questions. Because not all primary care docs do that routinely.
Okay, I have a question here.
Hi, this has really been very informative. I'm 71. I'm relatively active. I walk about 45 minutes a day, but I'm not doing enough core strengthening, which is, I got the message on that. I just had a bone density test, and the feedback was, oh, you've got early osteopenia, don't worry about it. I'm sitting there going, well, what the hell does that mean? And does that automatically translate to osteoarthritis? Does everybody get osteoarthritis past 70? Or, so help me out here.
Dr. Court?
And down here. Well, there's kind of an inverse relationship between osteoporosis and osteoarthritis. So if you have good bones, you tend to have bad joints. And if you have bad joints, you tend to have good bones. And there are some biological reasons for that. But the two don't have to be linked. I think the point that Michelle made, if you've had any joint injuries through athletics or whatever through your career, that automatically bumps you up for increased risk for osteoarthritis. For the first part of your question, though, if you're in that osteopenic category, that's what I called low bone mass or pre-osteoporosis, the highest number of fractures, and I hate to say this, in women over the age of 70 occurs in women in that group. So you are at risk for fracture by virtue of having low bone mass. So you're at the point where you should be having good conversations with your primary care provider about what you might be doing. Are you getting enough calcium? Are you taking in enough vitamin D? Are you doing the right types of exercise? And should you consider drug therapy? If you have a family history of osteoporosis, that's one of the other really important risk factors. So talk it over with your doc.
Okay.
Dr. Pascual Garrido.
In terms of the early osteoarthritis, right now we are only treating early osteoarthritis, which means like the same that happened with the bone that you say osteopenia, the same happens with the cartilage, and you call it chondropenia. So basically your cartilage starts to become thin. However, if you don't have any symptoms, you don't treat it. But you want to make sure that you are taking care of your joints, like doing activities, having vitamin D, fish oil, etc. I still think that in the future, we'll be treating patients that do not have symptoms, because right now, we cannot give you an ideal treatment just because we are diagnosing you too late. So this will be the same like happens with breast cancer. Like right now, you do a DNA, and you know that you have a risk for breast cancer, so that you treat that proactively. This will happen exactly the same with osteoarthritis. You will come to the office, we'll do a blood sample or a synovial fluid sample, and I will tell you, yes, you have 3 genes that are positive for osteoarthritis. Let's try and now start treating you with these drugs. I actually perform a lot of research in the lab with drugs that prevent the apoptosis, which is basically the chondrocyte death. So what happens in the cartilage, you start to lose the cells and also the extracellular matrix. So what we did in the lab, basically, we developed a model of osteoarthritis, and then we started treating those cells to make them go back to what they were when they're healthy. So these are all drugs that will probably come to the patients like probably in 10 or 15 years.
So Dr.
Thank you.
Pascual
Another
Garrido,
question here.
if I'm a runner and I've been told that I have moderate arthritis in my hip and my knee, should I stop running to protect my joints?
That's actually a great question because it's actually what normally my patients ask. If you have moderate osteoarthritis, I normally advise my patients to try to do a lot of cross-training, because the more you weight bearing on that joint, it will progressively make it worse. However, I never tell them to stop activities.
Okay, thank you.
Yeah.
Other questions? There's some down in the front.
Yes, one
also.
question here.
A quick question on weight-bearing exercises for those people who have to avoid impact, like the running and the jumping, but still want to do weight-bearing. Suggestions?
Strength training?
Walking and strength training are great weight-bearing exercises.
Yeah, no, I was going to say, strength training is weight-bearing, it's just not impact. So you can gradually load joints, and you can repetitively load joints, and you can sequentially load joints without the sudden impact or jarring effect that something like running would have. So I would advocate for strength training in that scenario. Do you agree?
Yeah, absolutely. And like Dr. Kortztalk said, like stair climbing. So usually with hips or knees, it's all about the angle. So, you know, where your cartilage is rubbed or where the bone is having pain. So, you know, you might walk stairs that are 6 inches instead of 12 inches or big steps. So I thought stair climbing is great for weight-bearing activity, and it doesn't have to be painful.
One other thought on this, and we don't have much research to support this, but usually we don't necessarily recommend water activity for improving bone health because, you know, if I push against a table, something set like this, I can generate much higher muscle forces than if I'm pushing against water. But if you put some fins, paddles on your hands or fins on your feet, or take water jugs, empty water jugs, and use those in water where you create more resistance, you can do some really good muscle strengthening exercises in water, and that's usually more comfortable for people who have joint pain.
Great tips. Amanda, are there, you know, we hear about, oh, you shouldn't take this kind of preparation of calcium, or this is the best vitamin D, or this is how do you make the decisions when we say you should be on a calcium supplement or you should be on vitamin D? It's like, is there some magic to it?
Yeah, there's not necessarily magic to it. I think you always have to look at your diet and say, am I getting it adequately in my diet, first of all? And I would say from a calcium perspective, you either need dairy in your diet or you need something that is calcium fortified in your diet, whether that's a fortified almond milk or a soy milk or tofu, something like that. Spinach is a source of calcium, but if you look on the handout that we provided, it's not a significant source of calcium. You have to eat a lot of spinach, and I don't know about you guys, but eating 6 cups of spinach doesn't sound too appealing to me. So dairy is going to be one of your best sources, and if you're not doing dairy, then yes, a calcium supplement is great. Calcium citrate, as we age, is going to be better absorbed because our stomachs become less acidic as we get older. So a citrate supplement is going to be a better option than a calcium carbonate.
What's older? Sorry.
Over the age of 50 is when we start to see declines in stomach acid, unfortunately. So, and it's not a bad idea to take citrate regardless, so definitely not a bad option. Vitamin D is a hard one to get in your diet. If you look at the handout, I show an example of a vitamin D deficient diet, which still is a very healthy diet. So unless you're eating cod liver oil or eating salmon on a very regular basis, you're likely not getting it from your diet. And I don't know about you guys, but it's really hard for me to get outside when it's sunny and beautiful out, especially during the week. So supplementation of vitamin D is typically a good idea.
Any kind, okay, or?
For vitamin D, I don't know exact specifics. That would be
The grocery
necessarily a
store,
better
we're
option.
good? Vitamin D in the grocery store?
Yeah,
we're good?
in the grocery store, you can get calcium vitamin D supplements that are together, which are very good options. And again, the recommendation is on there. We're looking for between 600 and 800 IUs per day.
Awesome.
Vitamin D is fat soluble though, so make sure you're taking that with a meal that does have some sort of fat source with it, or take it with your omega-3s or with your salmon to double up on vitamin D.
Thank you, Amanda.
Dr. St. Fard, we've got a question here in the back.
Sure.
I have a question about the stem cells for osteoarthritis. I was under the impression with your talk that that's still being researched with horses, but then you said you had a patient that you gave that to for her hip. Can I get that in my knee?
Yeah, so actually the research we are doing right now in horses is delivering the stem cells in a hydrogel. So basically, to make the cell stay longer, you can use scaffolds. And the scaffold we are using is a hydrogel, which has basically, the hydrogel is water. So in the future, what we are going to do, what we are doing that with right now with the hydrogel is printing. So in the future, what we will be doing with our patients, I will get an MRI from you, and I will see where the chondral defect is on you. And then with that information, that is called the blueprint, I will send that information to a printer, and the printer will be printing the hydrogel with the specific dimensions you need for your cartilage. So that's kind of the future also in cartilage, bioprinting. In terms of the stem cells that we are doing with our patients, is we are not delivering right now in a hydrogel, we are just leaving it in the joint for osteoarthritis. That is a different disease than focal chondral defects. So osteoarthritis is when your cartilage, all the surface is kind of chondropenic. And focal chondral defect is more common in young athletes, that they have like a focal chondral defect. But we are trying, the focal chondral defect, we are doing experiments in the horse. And the stem cells we are doing already in patients. And what we have seen is basically, we did a lot of in vitro studies of these stem cells and the bone marrow, and it has not so many stem cells, but it has a great amount of growth factors and proteins that makes your jaw more healthy and takes the pain away.
So I could schedule with you?
Yes, of course. I'll be happy to see you in the office.
Yeah, so all our clinics are open for business. That's good point, good point.
Yes, we have a question here.
Thank you. I actually have 2 questions, one for Dr. Court and one for Dr. Wolcott, and both pertains to female teenage competitive athletes. And with Dr. Court, is there a different protocol? I thought I heard you say there's a different protocol for using non-steroid, like Advil, before and after, depending on what age you are?
Yeah, that's very preliminary research. And the fact that nonsteroidal anti-inflammatory drugs in animals block bone formation, one of my great concerns is that our young athletes whose skeletons are still developing could be impairing their skeletal development if they're using NSAIDs. And you know, this is only anecdotal reports that we get, but that there are locker rooms or training rooms that literally have buckets of ibuprofen, and our athletes pop them like chiclets. So I think it is a real concern. I don't know that we'll be able to do research in that group. I mean, you know, there are new warnings out about NSAIDs. I don't know that I'll ever get another grant funded to study, to expand what we're doing. So I think all I can do at this point is urge caution. And even though in our young women, we did see that taking NSAIDs after exercise seemed to be beneficial, I do have some hypotheses about why that could occur. Until I can replicate that, I wouldn't use NSAIDs for that reason. I might say if you have to take your NSAIDs, if you really need them, it's probably better after exercise than before, at least if you're less than 60 years of age.
Okay, thank you. And real quick, from Dr. Wilcock, I'm curious, I've heard that some girls there's some statistic that girls who have torn their ACLs occur more often during their menstruation period. Is that true?
It seems to be true. It actually seems to be true that it happens either during your period or sort of right after. But that data was not well studied. I mean, it wasn't well performed, really. And I think what we didn't know, I mean, there's sort of this old wives' tale that the whole team cycles together. So you would see these, you know, peaks in a bunch of girls, and you'd sort of assume that. And then when you went and asked them, they were in varying portions of their period, whether it was early or mid or late in it, and it wasn't so much when they weren't having it. So they sort of drew these indirect conclusions from that. But I haven't been convinced by it, and I think that I'm certainly not convinced that we should be manipulating that in any way, shape, or form for performance. I think that, you know, that's just something that girls are going to go through and going to deal with, and that if we can maximize their biomechanics, I don't think it's going to be that relevant, truthfully, or at least I hope it won't, because I think that would be a very dangerous road to go down. It's sort of like steroids. I mean, you're manipulating hormones in teenagers, which is never a good idea, in my opinion.
And there's prevention programs, again, that Maria and the sports medicine PT department can help teams of people, so just contact Maria and they'll be able to set that up. I do have a question from the audience I'd like to read for the panel. Is hyaluronic acid in supplement form effective?
Oh, that's a great question. What kind of acid was it?
Hyaluronic acid.
Hyaluronic.
So the visco supplementation, glucosamine, chondroitin, is that the question, I think?
So I can answer that. Visco supplementation or hyaluronic acid with oral pills have not shown to be effective.
Okay.
So what I normally tell my patients that they're probably losing money and time with that. So I would not recommend that. There's a lot of studies showing that they are not as, you know, they basically don't prevent osteoarthritis or make you feel better.
Yeah, I have patients that ask me that all the time, and anecdotally will tell me they feel better. I think that's a placebo effect, but I also, you know, we're in evidence-based medicine here, and I believe in that, so I don't tell them to take it, but I do tell them if they're taking it and it makes them feel better. I don't think it's dangerous. It is a supplement. It's not something that we are concerned about as in a medication. So I agree. I don't recommend it, but I don't discourage people who are finding some benefit from taking it.
All right, we've got a question here in the back.
Hi, so there's a lot of discussion around the arthritis with your knees and hips. How about thumb joints or fingers? I feel like I know an awful lot of women who've done the surgery on their thumb joints, and I know I'm to that point now. Anything for hands?
I only know very little about that, but one of the surgeons that we had here a few years ago who's since moved on to Connecticut was doing a lot of studies. She was a hand surgeon doing a lot of studies on specifically base of the thumb arthritis in women. And there are some hormonal effects with that, and I think she was studying general tissue laxity. But I don't know really where her data was going with it, except that she was just getting a grant. There's certainly a link, and it probably is more genetic than anything else. But I'm not really sure what the recommendations are regarding that, because we're treating it after the fact in most cases. So I know that's not that helpful, but it's being studied, if that helps.
Okay, yes, we have a question here.
Questions in the front, too. You guys have roving microphones?
Yeah, we do.
Awesome.
I actually have two questions. One of them is regarding the therapeutic dose that you recommend as far as the fish oils and the vitamin D for women over 40.
So I don't necessarily prescribe therapeutic doses. So, I mean, when you speak to your physician, if they are seeing low vitamin D levels, those prescriptions can be as high as 10,000 IUs that you're taking on a weekly basis. If you are getting the 600 to 800 is typically what's recommended. Up to 2,000 IUs per day is what we typically see in supplement form, and that is safe. And your other question was on omega-3s? Is that correct?
Yeah, regarding the osteoarthritis.
Okay, so for osteoarthritis, there has been shown to be benefit. There's not necessarily a specific dosage that has been shown to be beneficial in that. For heart disease, I can tell you they prescribed up to 2,000 milligrams per day, and that is a therapeutic dose there. We do see a blood thinning effect with omega-3, so it's just important to check with your healthcare provider before you start taking bigger dosages of omega-3s. But you could go up to the 1,000 to 2,000 milligrams per day is going to be effective. However, I would say from a nutrition standpoint, you can definitely do that with food just as easily. So your fatty fish, salmon, tuna, mackerel, herring, if you do 2 servings of those a week, 2 3 to 4 ounce portions, you can get all of the omega-3s that you need for the week, just with 2 servings of fish per week. Vegetarian sources, you can do ground flaxseed, you can do chia seed, walnuts are also another good source of omega-3s. You would do those on a daily basis, and 2 tablespoons per day is going to be adequate from a vegetarian source standpoint.
And a comment from Dr. Evelina Berger. She's the Vice Chair of Orthopedic Surgery.
So I want to comment on the question on vitamin D. It's a very hot topic. Vitamin D, especially in spine surgery, is being researched all over in contribution for spine fusions. A few facts. We know that if you have low vitamin D, there's an association with back pain. We don't know what comes first, the back pain or the low vitamin D. Low vitamin D levels have also been identified in women with breast cancer. So in the spine, what we do, a preoperative, every patient that comes in for spine surgery gets a vitamin D level. If it's below 20, we give them 50,000 units once a week for 3 months. That's the only way you can get that level up therapeutically. And then we will retest them, and then we will go to either a maintenance of 2,000 or 5,000 units a day. Thank you.
Thank you, Dr. Berger.
Dr. St. Fard, I know that you have one question. I want to be respectful of everybody's time tonight, so I'm going to let you answer that. We've got one last question from the audience, and then we will adjourn. But I know that our panelists will be around afterwards if anybody from the audience has specific questions to ask. So
Awesome. This is the beautiful question. Please address, panel, Depo-Provera contraception use in women, the effect on bone density, bone loss, reversibility, calcium recommendation, and exercise advice. That should hit everybody.
Bad for bone.
Thank you, Dr. Court. Anybody else want to comment on Depo-Provera? Bad for bone. Reversible?
We all concur.
Okay.
Right, one last question here from the audience.
Don't know if it's reversible. Go ahead.
What's your insight on the drug called Forteo? Is it good for the bones? Does it? Do you recommend it?
Yeah, Forteo, I don't use the trade names.
Teriparatide?
That's teriparatide.
Yeah,
Yeah,
teriparatide.
that is the one at the bottom that I pointed out that is the only drug that is used to build new bone. Its indications right now are only for severe osteoporosis, so it's not used very commonly yet. It's very expensive. It requires injections, but I think it is probably the leader of new drugs that are going to be coming that will have similar actions and probably be used more widely.